Hello colleagues, and thank you for joining another edition of Transforming WHO. This is a series of video interviews where I talk to colleagues inside and outside of WHO about what we do in the World Health Organization and about how we change and transform to meet the challenges of global health. And today I'm very happy to be joined here in the studio in Geneva by Pascale Alloutey, who is the Director for Sexual and Reproductive Health, and her responsibilities also include leading the special program on human reproduction. Welcome, Pascale, and thank you for joining.
Thank you very much, sir.
So first, a little bit about your background. You're from Ghana, your nationality, and you started in your country training as a nurse and midwife originally. And I actually have proof of that if anybody's doubting that. So let's pull up the first slide here. This is actually your license, your certificate of registration as a certified nurse and midwife in Ghana. I don't know, could you still work as a nurse and midwife back in Ghana if you wanted to?
I would certainly need to re-register.
Yeah.
I think clinical practice has moved on a bit since I was last in a hospital.
I could
but
imagine.
I would certainly love to.
Yeah.
Yeah.
You still have it in you.
Absolutely.
So do I. Actually, I trained as an obstetrician and worked for many years, but it's been a while, so I probably need to be retrained as well. Anyway, you quickly moved into academia and research. I mean, you did a Master's of Public Health and a doctoral degree in Australia. And then in the 1990s, you went back in the late 90s to your own country in Ghana. You did some research in the field, working with women, looking at pregnancy care, also at traditional practices like female genital mutilation, etc. That was very much of your early research, right?
That's correct.
And then you have a very distinguished academic career. You had leading academic positions in Australia, in the United Kingdom, in Malaysia. From the late 90s, you also started working with WHO on various programs, serving on advisory committees, etc. You also previously chaired or co-chaired the Lancet Commission on Gender and Global Health. So that's sort of very much of your academic and professional career is in gender, global health. And then, of course, you joined WHO in 2022 as in your current position. Is that a fair description of your very long and impressive career?
A fair description, yes. I think when you talk about it, it sounds like it was very nicely planned and it progressed. But it was very much about opportunities and a lot of curiosity.
Ah, yes.
So with starting off in particularly in community midwifery, when I had the opportunity to do postgraduate study, I jumped at it. It was initially in primary health care. And it was a really nice opportunity at the time in Ghana, quite complex actually, because it was the primary healthcare movement in Ghana was really pushed by a military government, but it meant that there was a lot of community mobilization. And so being a part of that and really being a part of a political era that was very much about listening to communities. It may not necessarily have been the way that I would have chosen it under the military rule, but it really kind of steeped me in working with communities and trying to understand, and that's where the anthropology bit came in as well. And so with the research for my PhD, I was very, very much committed to midwifery, but it was also in a community in Ghana that had a whole range of tropical diseases. So I did both. I looked at tropical diseases in pregnancy, and it was, I mean, just being curious, trying to understand why everything happened the way it was, why things didn't work, and it's such a wonderful foundation for a research career.
Yeah, curiosity is a strong driver of research for sure. So one of your current responsibilities here in WHO is actually to lead the special program on human reproduction, which has a history of more than 50 years. It was founded in 1972 as the Human Reproduction Program, and and is still ongoing and now under your leadership. Can you speak a little bit to why this program was groundbreaking back in the 1970s and what has been its successes?
Okay, so it has a history that goes a little bit before 1972. It arose from a World Health Assembly resolution, a World Health Assembly meeting that was that raised the importance of population regulation, and it was the early days of the pill. And so on. So there was the World Health Assembly.
On family planning.
A focus on family planning. A focus actually at the time, which was quite Malthusian. There was a concern about a population explosion and regulation and so on. And so there was a call for the evidence behind it and the science behind it. So that kind of started in the late 60s. And by 1972, it was clear that there was a need for a much more permanent program within WHO. So that's where and it was set up very specifically to ensure the global evidence behind it, that the research could be commissioned, that it could be coordinated across countries, because it was very clearly not an issue that was within borders. It was very clearly a global health issue. So in 1972, it became a formal program. And in 1988, it then became, there was a little bit of a controversy. So the controversy has been going for a while, but a number of member states that were not comfortable with the idea of fertility regulation. And so it then, in 1988, it became a UN co-sponsored program that then included the World Bank, UNDP, UNFPA, and then later on UNICEF joined as well as part of it. And the governance was taken outside of the World Health Assembly into a separate governance. So it's under what's called the Policy and Coordination Committee, PCC. So it still has member states. It has a group that is elected by the regional committees of WHO, so it's global representation. IPPF, which is the International Planned Parenthood Federation, is an observer, as is UNAIDS as well. So it is very relevant topics to sexual and reproductive health, but with member state governance and absolute.
So these days it's more of a special program. WHO, of course, has a leading role supporting the Secretariat under your leadership, but it's a broader program. And over the years, more than 5 decades, focused very much on training, research, low and middle income countries in this sort of whole reproductive health space, right?
That's correct.
Yeah.
It's been responsible in terms of the achievements. These are things that we take for granted today, but that were certainly groundbreaking and continue to be. So a whole range of contraceptive technologies, long-acting contraception, the trials that led to the work on mother-to-child transmission in HIV, the emergency contraception. So all of these are technologies.
And this is, of course, a field. I mean, I worked in that field for many years myself. I know very well. It's a field that has had a lot of scientific breakthroughs, 1960s, 70s, 80s, 90s, as you mentioned. But it's also a field that always had a lot of politics ongoing, back and forth. And to take it a little bit further up in the 1990s, there are 2 big international conferences that I think are important in this field. One is the 1995 Beijing International Conference on Women's Rights, which basically institute very strong language on gender equality in society and in health, etc. And the other very important event is the Cairo Conference in 1994 that specifically focused on sexual and reproductive health and rights, institute some very strong language on exactly these are rights to reproductive health and services, also rights to your own reproduction and fertility, support for infertility even, and also support for abortion services. Of course, controversial, but still it was decided in '94.
That's correct. And so what the conference, what the Cairo conference did, ICPD, the International Conference on Population and Development, what that did was actually pivot the work of the program, the special program, from what was very much focused on the science of fertility regulation to one that was much more rights-based and became patient-centered and rights-based. So that expanded the mandate to be what it is now, which is comprehensive sexual and reproductive health and rights across the life course. Very much centered in gender equality and human rights.
And the rights-based approach, of course, was also what WHO was founded on back in 1948 with health as a human right, health for all. That was then taken further in the 1994 Cairo document that serves in many ways as a guiding document, not only for WHO's work, but also for UNFPA, UNICEF, and others, right?
Yes. And what happened as a result of that was that the program then actually put together a reproductive health strategy, and that was actually passed by member states in the World Health Assembly. So it took the work of and the evidence that had been generated from HRP over the years, layered on the ICPD, and it was passed. The reproductive health strategy, and that is still the foundation of our work through to today, from 2004.
But I think it's fair to say, and I've also followed the WHO and our governing bodies for quite some time, it's fair to say it hasn't been smooth sailing for the last 30 years in this field, because it is very political in many of our member states. I mean, political changes also influence, for instance, reproductive rights, abortion services, etc. So now, more than 30 years later, what would you say are the state of the Cairo recommendations?
Well, there are a couple of ways of looking at it. One is if we focused on the specific outcomes, the health outcomes as a result of Cairo, those are translated into things like the maternal mortality outcomes, access to contraception, and so on. We're certainly not where we would like to be. And I think we will raise that a little bit later, but we know that we've stagnated in terms of the maternal mortality figures. There absolutely has been progress. We can't, there's no question about that. But I do think that while we have made significant progress through the improvement of health services and health systems and general improvement in gender equality and so on, that have all contributed to improvements, I think we are part of the stagnation is also in continuing to strengthen our health systems, but it may be that we also need to go that last mile. And where the nature of our work has done the most for a lot, but we have to accelerate to get to the last mile to be able to really bring it home.
It seems so. I was reading we just recently celebrated International Women's Day on 8th of March. The UN Secretary General and UN Women, they issued a report, which was basically also a 30 years sort of status of the Beijing Declaration. In that report was some progress noted, as you say. I mean, for instance, access to family planning. That has actually been progress. It's not perfect, but it's actually better. But still, I mean, I think that report was highlighting that women, generally speaking, globally, have only 65% of the legal rights of men. So in many member states, I mean, we are not there. And even on the 8th of March, when this was presented for the conference of the rights of women in New York, the Secretary General of the UN was saying that he was seeing patriarchy, misogyny, sort of having a heyday in these days. I mean, so he was speaking very strongly to what he perceived challenges in this area. Do you see the
That's
same?
correct. Absolutely, and it's something that is very worrisome. It is obviously continues to be a problem in low and middle income countries, but it is global now. I mean, the regression in women's rights globally it breaks my heart that we're still having to talk about these issues, fundamental women's rights issues in 2025. And it is I guess the strength of doing this work out of WHO is that we are backed by the evidence. We can provide the data, and that for us is the strongest tool we have in our toolbox.
So the science-based, evidence-based approach, building on the principles of our constitution, the rights-based and these other international declarations, and then the science. That's basically what we can do in WHO.
That's correct.
But as a scientist in this field for more than 3 decades, Pascale, why do you think that the issue of women's reproduction and women's sexual life, why is that a constant political battlefield?
Oh, that's a big question. So there is it is, and this is one of the nice things about my curiosity and having come up through learning through communities and so on, that there are often the sciences that we don't use enough are the political sciences, the social sciences, and so on, to really understand what is happening within communities, within countries, and what the change in the global health politics, how that impacts on women. If I can go back a little bit to the SDGs, the MDGs and then the SDGs, certainly it brought women's equality and women's empowerment very much to the fore. Countries actually had to and were accountable for girls' education and so on, and that has clearly been been responsible for some of the progress. We unfortunately are seeing a backlash in a lot of that, and I think we will. While the progress has been clear, and I also just one more point I want to add in there is the introduction of the feminist foreign policy, which a lot of countries are pulling back from at the moment. Again, what that did was provide a very strong accountability mechanism. With all of that withdrawing, that then takes away the push to actually go that last mile to ensure that equity is an important part of the work that we do. And the point at which you don't recognize that largely women start on the back foot in terms of equity, and therefore that women are that we have to be very clear about what the issues are for women throughout at least maternal mortality, because that gives us something to count. But the reality is, before the 9-month period that is of interest, there are a whole range of other women's health-related issues, and this is why sexual and reproductive health is important, that by the time you come to the period of pregnancy, the woman should have come into that pregnancy out of choice, should have had access to contraception to make that decision, should have had access to safe, comprehensive abortion care if she did need it, and have access to information to ensure that she is safe, not subject to gender-based violence, not subject to traditional practices, and so on. So it is very much. And I would
I can attest to all of that, having worked as an obstetrician for many, many years. I mean, it's extremely important. It's not only the pregnancy and the delivery. I mean, it's basically a healthy young woman before becoming pregnant. And I would even make it more holistic and say she also has a right for education and a place in society and meaningful employment and safety and health to make that pregnancy and that delivery and that family safe and good. So you spoke to maternal mortality because that is a very, very strong indicator because most maternal mortality is preventable. When we speak about maternal mortality, this is basically a woman dying from pregnancy, delivery, or the immediate postpartum period. Not everything is preventable, but in a strong healthcare system, most cases can be preventable. So that's been a very clear indicator. We've followed it for decades. It was in the Millennium Development Goals, it's in the Sustainable Development Goal. And I actually have a graph showing, let's just look at the data here. So this is a graph. We are tracking it from WHO. This is a global data. If we break it down into countries, low, middle, high income, it looks different. So basically, looking across the decades, it seems like we have made a lot of progress. We've really developed a lot of solutions to support women, but it's sort of stagnating in the last couple of years. In this graph, we are roughly at 225 per 100,000 pregnant women, and the SDG target is 70 per 100,000. So we are not on track. We're not on track to meet the 2030 SDG goal for this indicator, and it seems to be leveling off after having progress. Why is that?
We still need to continue to strengthen our health systems.
Yeah.
As I'd mentioned before, I think we started off with a very low base. I mean, the numbers of deaths at the beginning of the millennium was awful. Yeah. And we have the evidence now, partly from HRP's work, on the importance of having skilled birth attendants, on the importance of the number of antenatal clinics, antenatal visits, the sorts of risks that need to be assessed during pregnancy, and increasingly the actual birth experience. So in terms of the evidence on cesarean sections when interventions are required and not postpartum hemorrhage, which is one of the highest causes of maternal mortality. Where we have just last year, actually, the emotive trials that we had done have now put together a package, a bundle of interventions to prevent postpartum hemorrhage and so on. So the science is there. The what we need to do largely, and it's always we can continue to do the research. It's a number of things. It's being able to get the right interventions to the right places. Yeah. During one of the recent consultations we had for the postpartum hemorrhage in particular, there was a summit that we convened. And what was clear, just talking, and we had people from the community, we had clinicians and specialists and so on. What was very clear from those discussions, for instance, was that while we may have the interventions, particularly around the perinatal period, they are not getting to where they're needed. Yeah. So there's still women in rural communities who cannot get to the district
So it's basically
hospital.
About strengthening healthcare system. We have the science.
Absolutely.
We know what is driving this. The postpartum hemorrhage, the hypertensive diseases of preeclampsia, infections. Yeah. We have the tools to deal with this. We know what works. And actually, these are not very expensive tools. I mean, they're very, very basic tools, including the drugs, etc. Yeah. But it's all about access. It's very, very much about having a healthcare system and also having a skilled attendant for the pregnant women and mother. And you and me, we have both worked as birth attendants in our previous clinical life. So it always hurts my heart when I know what is needed is just a skilled birth attendant. Yeah. And the woman is not getting that. A woman delivering a child anywhere in the world not having a skilled attendant by her side. So that, of course, she should have. That's a right. It's more than 90% in most high and middle income countries. In sub-Saharan Africa, in many countries, like 65% of the women. So 1/3 don't have it.
That's correct.
And it's actually not improving. So how can we support governments and member states in doing this?
Well, there is a midwifery model that's been put together. We do even within the professions. It has taken a while for the importance of the midwife. to be recognized, and we are getting there. There's
previously it was too doctor
it was
dominated.
yes, that's correct, and it is and we. I unfortunately don't see a world where you can get a doctor everywhere.
No, it's not needed
so there's
either.
Indeed.
I can say that.
So there are a whole range of different levels of task shifting, but very much midwifery is so important because they often midwives are often the people that are known by the communities. They engage with women throughout the pregnancy, so there's a relationship, and you can get them, and they are able to do a whole range of services, including broadly the range of sexual and reproductive health services as well. So we have to get the people, and we have to get the skilled staff out, the skilled workforce out that can help to manage these some of these problems.
And we're talking about many of these midwives, women, they are already there in the societies. They need to be supported. We are not talking about needing to educate everybody in the university. It doesn't need to be a skilled medical doctor, as you say, for most of these cases. So currently we are facing a very great crisis, I would say, in global health. I mean, with the withdrawal of the United States, also withdrawal of funding, not only for WHO, also for many of our colleagues in the multilateral system, but even more concerning, I would say, a withdrawal of funding for many global health programs in the field. Is this affecting what we're talking about as well?
Absolutely. I know my colleagues in the division are still collecting the data on that, and there are a number of others as well collecting the data to actually demonstrate just how devastating this is going to be. I think if we look back to, and this will be evident in the new data that will be released on maternal mortality, but it was very clear, the blip in the numbers of deaths, maternal deaths, is very evident over the COVID period. And I think that should be for us very much the canary in the coal mine. That demonstrates that if you don't have a resilient health system, that maternal mortality should be the one thing that we should be able to manage. So
that must be because of disruption of healthcare services during the pandemic.
Yeah, and there is no way we will not see that with the very severe reduction in access.
We see that all the time, Pascal. As you say, it's a canary in the mine. I mean, the terrible, devastating war in Gaza. I mean, the first affected, they have a high fertility in Gaza. But I mean, it broke my heart hearing about women who could not deliver safely. Or even I heard about colleagues who were doing a cesarean section that needed to be done, but without anesthesia in Gaza. We saw it in Western Africa 10 years ago with the Ebola outbreak. I mean, a lot of the deaths were actually not related to Ebola. That was related to disruption of healthcare services. So it's certainly what we see. So this is concerning the lack of funding, the deprioritization of global health, but it's also more than funding. I mean, we also see a challenge to the core principles and values, even the science that we are talking about here, that goes back to what we talked about, the WHO Constitution, the Reproduction. And we see that, for instance, in the re-emergence of so-called gag rules, which are major funders who say we will not fund a program if that program provides reproductive services, abortion services, etc. So why do we see a re-emergence of this now?
I think it goes with the global politic that is happening, a real resurgence of religious, often fundamentalism. That is a very strong part of the global discussions at the moment. At some level, I don't think it is necessarily just about sexual and reproductive health. I do think that there is a breakdown in some of the fundamental values that define multilateralism. I mean, that is what the whole system is about. It's about ensuring equity and fairness. It's the conscience of the world. Multilateralism.
So a broader challenge to the rule-based, rights-based multilateralism.
Correct. Yeah.
But do you see a future for multilateralism?
Absolutely. I mean, I know our systems are not always perfect, and I know we need recalibration. whenever. But it really is. It is the one thing that brings us together as humanity. That we are able to remember that we are a part of a community, that we're part of a global community, and that we need to look after each other. And that is for me very much what defines the importance of multilateralism, and absolutely worth protecting.
So there is a future for multilateralism.
There is absolutely a future. And I think for us in global health, it is particularly important because what it does is it raises this notion of the individual, particularly in public health, to recognizing that, yes, the individual is important absolutely as a rights holder, but as part of a community, what we do impacts on our fellow citizens, our fellow human beings, and therefore we have a collective responsibility as well to look after each other. And that comes very much under the umbrella of multilateralism. And
that's a very strong message. So this is about community locally, but also about community globally. Thank you very much, Pascale, for joining me in the studio, and thank you very much, colleagues, for tuning in to Transforming WHO. And do stay tuned on this channel to look for upcoming episodes. Yeah!